Hello, I'm Dr. Masha Livhits.
Hi, I'm James Wu. We're both endocrine surgeons at the UCLA Endocrine Center, and today we'd like to talk to you about Graves' disease. This is an outline of what we're going to be talking about today. We're going to start with what is Graves' disease, then we'll talk about the diagnosis and workup. We'll go over some treatment options for the disease, and finally we'll cover what we think about when we think about surgery for Graves'.
So let's just start with what the thyroid gland is and what its job is. So the thyroid is the butterfly-shaped organ that maybe Dr. Wu could point to over here. It's in the front of your neck, and it produces thyroid hormones, which are called T3 and T4, that controls your metabolism. So when the thyroid produces too much hormone, we refer to that as hyperthyroidism. The most common cause of hyperthyroidism or excess thyroid hormone production is Graves' disease. And Graves' disease is when the immune system produces an antibody that stimulates the thyroid gland to produce too much hormone.
So why is this bad for you? Well, it may sound good to have an overactive metabolism, but it can produce a lot of stress on your body, and that can lead to feelings of anxiety, heart palpitations, trouble sleeping, weight loss, irregular menstrual cycles, arrhythmias, and finally osteoporosis.
And I just want to emphasize, I have some patients who have some reservations about being treated for Graves' disease because they are worried that they might gain weight with treatment. But really, when you have Graves' disease, your body is producing too much thyroid hormone. And although, yes, this may increase your metabolism and cause some people to gain weight, it has so many more bad effects and stressful effects on your body. That is really not the way that we want to lose weight.
That's right. And being overly active can make you feel tired too. Just like if you drink too much coffee, you're going to feel a little bit stressed out all the time.
And how do we diagnose Graves' disease? Well, actually, most endocrine conditions like Graves' disease are diagnosed with laboratory values. So we would see in a blood test that the thyroid hormone level is high. This is the T3 and T4. And I'm going to show you just this picture here. The thyroid gland produces T3 and T4 hormones, and those are the hormones that actually control your metabolism. But there is a negative feedback loop. So if the T3 and T4 are high, well, your brain senses that, and it wants to lower the production of this TSH, or thyroid stimulating hormone, to try to regulate the thyroid so that it's not producing so much hormone. So what we see in Graves' disease is that the T3 and T4 are high because of the antibody that's produced by the immune system, and then in return the TSH is very low as your brain is trying to bring the thyroid hormone level back to normal, but it can't. And then furthermore, we could check the actual antibody level, which is the thyrotropin receptor antibody level, and that would be elevated in Graves' disease.
Another way we can confirm the diagnosis is getting a radioiodine uptake scan. And what this is we give patients a pill of iodine that's labeled with a slightly radioactive tracer, and we look to see where it goes into the neck. This is a picture of every little particle is where one little radioactive iodine molecule has gone. And you can see on the B side, Graves' disease side, that there is a lot of uptake throughout the entire thyroid, which again is shaped like a butterfly.
And one way this can be helpful is, for example, we said Graves is the most common cause of hyperthyroidism, but some people have a thyroid nodule that's a hot or toxic nodule, and it's producing too much thyroid hormone. So if we saw a nodule on ultrasound, we could do this uptake scan, and then instead of what you see in Graves' disease, where all of this has activity in the entire thyroid, well, if you had a nodule producing hormone, you would just see this concentrated in a particular area of the nodule, and everywhere else would be quiet. So it can help us to determine that the cause of the hyperthyroidism really is Graves' disease. So let's now talk about treatment options for Graves' disease. And we sort of start at the bottom with medication. That's actually the most common treatment modality that's used in the United States. About 60% of patients with Graves' disease in the United States are treated with medication alone. Then we go to radioactive iodine ablation, and we're moving up towards things that have a higher rate of definitive cure, but also are a little bit more invasive. So about a third of patients in the United States are treated with radioactive iodine ablation, and we'll get into what that is in just a minute. And only about 6% of patients right now in the United States are treated with surgery for Graves' disease.
That's right. And typically when we start treatment, everybody starts on that bottom tier just getting medication. And only after a while, and we think that that is not enough to get rid of the Graves' disease, then we kind of move up and think about these other treatments which are, as Masha said, definitive. So let's go over some of the medications for Graves' disease. We refer to these as antithyroid medications. What they really do is they go to the cells of the thyroid and they block the production of the hormone. And there's two main medications, methimazole and polypropylthiouracil, PTUs for short. These have moderate rates of long-term cure. After about 5 years, about 50% or so of patients will have remission, or the Graves' disease will end on its own after being treated with medication. Potentially, these medications can lead to hypothyroidism if what the leftover thyroid cells don't produce enough thyroid hormone for the rest of the body. The side effects of these medications, they're separated into minor category, major category. For the minor ones, it's hives, rash, GI upset, and there are a few major side effects that are very rare. Agranulocytosis, which is where your body stops producing the white blood cells it needs to fight infection, hepatitis, or inflammation of the liver, and potentially if people become pregnant while taking it, there is some risk of birth defects.
And so again, the main benefit of the medication is that you could potentially avoid something more invasive like the radioactive iodine or the surgery and have a chance of having a long-term cure with just the medication alone. And because we're not doing anything to the rest of the thyroid, we're not removing it or ablating it, it could actually just function so that at some point you would be off of all medication and you would not be hypothyroid and require thyroid replacement. So this was a study of patients with Graves' disease in the United States. And what we saw was that as we go along with treatment, and this is the medication arm, the long-term cure rate is about 50% after 12 to 18 months. So that means is that if you're on the medication, most likely you're going to be on it for at least a year. But then at a certain point, after a year to a year and a half, you could stop the medication and have about a 50% chance of a long-term cure, and about a 50% chance that at some point in your life, this will reactivate and you will sort of develop Graves' disease again. And sometimes we see that after, let's say, a stressful period in somebody's life. There can be physical stress or emotional stress or illness. That kind of thing can actually trigger sort of a resurgence of the Graves' disease. And if we check the laboratory values of the thyroid antibodies that we mentioned earlier, if those remain elevated, there's a higher chance that this Graves' disease may come back in an individual, as opposed to if the antibody levels come to normal, then there's a higher chance you'll have a long-term cure.
So what happens if you start taking the medication, more time goes by, what happens? Well, as we discussed a little bit earlier, that many patients do experience some side effects, and up to 1/3 of them will stop the medication and want to try something else because of those side effects. Here's another breakdown and a table of what those side effects are and their rate. And again, if you look at the very serious ones at the bottom, agranulocytosis, liver toxicity, they're very rare. And in general, these medications are well tolerated, and some patients take these medications for a very long time and do fine.
Right, so we don't want to give you a skewed perspective. I mean, there's a reason that the medication is the most common treatment modality in the United States, is that in general, the complication rate, particularly of any serious complications, is actually quite low. And there's a real chance that this could provide a permanent cure. Okay, so let's move on now to, let's say if the medication is not working or is not tolerated, or if a patient continues to have persistent or recurrent Graves' symptoms despite the medication, then we can think about radioactive iodine ablation for Graves' disease. So this is where a capsule of sodium iodine is taken by mouth. It's a one-time treatment, and it is rapidly concentrated in the thyroid, and it damages or ablates the entire thyroid. So this process takes about 6 to 18 weeks, so it's not an immediate cure, but over that period of time, eventually the entire thyroid should be ablated, and the rate of permanent cure of Graves is greater than 80%. Some patients, if they're not cured, could have a second treatment and then still be cured. Now, since this is ablating or killing off really all of the thyroid, most patients will develop hypothyroidism, where the thyroid hormone level is low and require thyroid hormone supplementation. However, that is a very safe medication to be on for the rest of your life. That's the levothyroxine is what we typically supplement, or a synthetic T4 hormone. So somebody who is hypothyroid can be on that medication really without a significant risk of any side effects, and it's a very stable dose. So as opposed to somebody with Graves' disease, if you're on the medication, there can be a lot of ups and downs because the thyroid hormone production is so unpredictable from the thyroid. If you're hypothyroid, you have a stable dose of the medication, and it's very good quality of life. Now, one thing that we'll talk about a little bit later is Graves' eye disease and the potential for radioactive iodine to worsen eye disease.
This is just some key things to think about if you're considering radioactive iodine therapy. In general, the treatment is very well tolerated. Again, it's a one-time pill that you take. The short-term side effects are listed here: dry mouth, some pain, inflammation of where your salivary glands are, because the iodine will go there and cause some inflammation, some mild neck swelling, and in rare cases, some excessive tearing due to obstruction of the tear ducts. After treatment, patients do have to avoid close contact with others for between 3 and 10 days based on the dose of radioactive iodine that you receive. However, many patients are able to be at home. They just seclude themselves for a few days. Couple other considerations. Women are advised to avoid pregnancy after receiving the radioactive iodine for 4 to 6 months. This is both to make sure that their thyroid hormone levels are stable and also to avoid any ill effects of the radioactivity on the pregnancy. Same thing, men are asked to wait 3 or 4 months before they try to conceive to allow turnover of their semen. Finally, one question that we get a lot is this going to increase the risk of future cancers? Because that's been reported out recently. And it's that small amount of radioactivity that many, many years later may contribute to a second cancer. So this is what it is. They looked at, after a long time, what happens to patients who receive radioactive iodine. And the actual percentages do go up slightly. But if you look, in the course of 30 years after treatment, the chances of you getting a secondary cancer coming from another organ in your body is 0.35%. And that's compared to patients who had never received radioactive iodine. That risk is still 0.28%. So you can see that the actual increase is relatively substantial, but the absolute magnitude of it is still quite low.
Yes, I just want to reiterate, it's a pretty common concern that patients have about the potential of the radioactive iodine to induce a cancer in the future. And the good thing is that when we really study this, that increased risk of cancer, although it may be real, it's very small. Now, of course, that doesn't diminish the fact that people may be concerned about it and may just choose that they don't want to get that. But it is reassuring that when we study this, the increased risk of malignancy is pretty small.
That's right. And I think sometimes in how it's shared sounds a little scarier than what it really is, because people will say, well, the risk is increased by 20 or 30%. So it's always good to think about what the absolute risk is. This is one quick study that we share with a lot of our patients that looked at what is the quality of life after these 3 different treatments. And what this study did is they did a survey that asked patients about many different aspects of their life well after they got treated for their Graves' disease. And if you look in this figure, they ask about eye symptoms, feeling tired, their anxiety, depression, so every aspect. And what they found, surprisingly, was that patients who received radioactive iodine reported slightly lower quality of life scores compared to people who just stayed on medication or got surgery. We don't really have an understanding of why that was. but I think that this is just another piece of information for our patients to think about.
Yeah, and we want you to know that we, as a medical community, really, we care about this, how patients feel. We're doing our best to study this, to make sure that our treatments are really improving people's quality of life as much as they can. I mean, of course, we care about the potential for heart arrhythmias, osteoporosis with long-term Graves' disease, but for an individual patient, I think a lot of times the priority is how you feel at that moment and how you'll feel long-term with the different treatments that are available. So this is something that we're really trying to study as a community, what will make patients feel the best in terms of their quality of life long-term. Okay, so let's talk about our third option, which is surgery for Graves' disease. Surgery involves usually complete removal of the entire thyroid so that the Graves' disease cannot come back, because we know this is an immune system mediated disease, and the antibodies will attack any of the thyroid that is remaining, so we really want to remove all of it. One of the benefits is a very fast resolution of symptoms. The thyroid hormone levels were dropped very quickly. So with radioiodine ablation, we said it may take a couple of months for the levels to drop. With surgery, it is very quick, even within a matter of days. Now, of course, we're removing the entire thyroid, so then you will have permanent hypothyroidism and require the thyroid hormone supplementation for the rest of your life. And there are, of course, some risks of surgery and anesthesia, which we will talk about. But this is, the thyroid, again, that butterfly-shaped organ in front of your trachea, and then the whole thing is removed. And here are the little parathyroid glands, which control the calcium and ideally are left behind after the surgery.
So one quick note about thyroid eye disease that we touched on a little bit earlier. So what is thyroid eye disease? The antibody responsible for all the mayhem in Graves' disease also binds to something that lives around the eyes and can cause eye symptoms. And these symptoms include a feeling of grittiness in the eyes, swelling around the eyes, and probably the thing that people recognize most is this kind of eye bulging that is very characteristic of Graves' disease, shown in these pictures here. About 20 to 25% of patients who have Graves' disease have some eye disease, and some of it is very subtle. One of the key differences in radioactive iodine versus surgery as a definitive treatment is that the radioactive iodine can worsen the eye disease right after treatment, whereas surgery does not. It is important to point out that there is kind of a new development in the treatment of thyroid eye disease, a new antibody treatment called teprotumumab, and that may change how these interactions go, because this antibody has been able to, before definitive treatment of the Graves' disease, ameliorate a lot of these eye symptoms significantly. We don't know yet how that interplays with these treatments.
And this is where it's really important to have a whole team involved in your care. You have the endocrinologist. If you have eye disease, you have the eye doctor, potentially the surgeon, where if you're considering surgical treatment, the nuclear medicine doctor, if you're thinking about radiative iodine ablation, and then the whole team can get together and discuss, and every individual is different, depending on the severity of eye disease. If it's very mild, perhaps radiative iodine is still an option. So you just want to have that good team assembled so that you know what treatment options are really available for you. So which patients would do best with surgery? We always like to ultrasound patients and really see what the thyroid looks like. If there is somebody who also has a suspicious thyroid nodule or thyroid cancer, then of course that patient would benefit from having thyroid surgery to have that nodule or cancer removed and then the entire thyroid removed to treat the Graves' disease. Some people just have a large goiter where the entire thyroid is very enlarged and they have Graves' disease. In that case, I also think that surgery really should be a consideration because if you have a really enlarged thyroid that's going to be pushing on things, then removal would probably benefit to remove any local compressive symptoms. Now, I think Dr. Wu mentioned earlier, most people will start with the medical management. And we give it quite some time, at least a year if everything's going well, there aren't side effects, to see if you could just go into remission with medication alone. So most of our patients will have had some trial of a medication and either it didn't cause remission, there have been too many ups and downs, or there were side effects from the medication. If you're planning to become pregnant soon, if you're breastfeeding, you cannot get radiative iodine ablation. And there's probably some benefit to not having to be on the thyroid medications potentially during the antithyroid medications potentially during the pregnancy. If you have eye disease, Graves' eye disease, those are often patients referred to us for surgery. And in general, it would be somebody who's healthy enough to undergo a surgery under general anesthesia. We want to think about risk factors that may increase the risk of complications during this surgery. So a prior neck operation, for example, that would result in scar tissue may increase the risk of surgical complications. That may not be the best candidate for surgery. Could still be an option. So let's talk a little bit more about the specific risks of surgery for Graves' disease. They are a little bit higher compared to other thyroid surgery due to all the inflammation that we encounter in Graves' disease. So, as opposed to somebody who just has a benign thyroid nodule that's being removed or a small thyroid cancer even, Graves' disease is associated with higher complication rate. What are those complications? Bleeding is about 1%, I would say just minimally higher in Graves' disease, but we tend to keep patients overnight in the hospital because of all that inflammation to make sure that there's no bleeding overnight. Then there's the low calcium, which is associated with these parathyroid glands. I think that's maybe the most critical complication to think about for people with Graves' disease. So again, if you look at the thyroid here, the parathyroid glands are these little yellow guys, and they're like a little grain of rice. That's their size. And you see all of this blood supply that's supplying the thyroid, these little red tubes over here. Well, we have to ligate all of that blood supply to remove the thyroid. And in Graves' disease, there's a lot of blood supply there. We have to remove all of that. But then we have to really look at these parathyroid glands and make sure that they have enough blood supply to survive. So that's really a critical portion, and if somehow that doesn't go well, then somebody could have low calcium. The risk of temporary low calcium after Graves' disease is 12%, I would say at least. And then for permanent, it's about 1 to 3%. And that's really a major inconvenience to people. If you have permanent low calcium, you may have to take tons and tons of calcium supplementation, and we really want to do everything we can to prevent that. And then there's the risk of hoarseness because the vocal cord nerves are right here in this area. We really want to be careful, of course, to preserve those. There is an up to 10% risk of temporary hoarseness if the nerve is stretched or inflamed during the surgery, recovers on its own, less than 1% chance of that being permanent. And so the surgeon experience is really critical. There's been a lot of data that increase in surgical volume and experience lessens complications for all kinds of various procedures, but it's certainly the case for Graves' disease. So you just want to see a thyroid surgeon who operates a lot on the thyroid gland to make sure that your complication rate will be as low as possible.
That's right. And I think one thing that kind of plays into this risk of low calcium is that some patients who have Graves' disease run into something after surgery we refer to as hungry bone syndrome. What that really is when the thyroid gland is making all this extra hormone, some of that hormone goes to the bones and increases the turnover activity at the bone. So it's currently breaking down bone, making new bone, and that's one of the reasons why one of the risks of untreated Graves' disease is osteoporosis. So all of a sudden, we've fixed the problem by removing all the extra thyroid tissue, causing all the extra hormone, and now the bones go in reverse, where now they've been hungry for calcium all this time, and they pull all that calcium in the blood back into the bones, giving people the symptoms of having low calcium. But we see that often enough, and all we need to do is keep an eye on patients in the hospital and give them the calcium they need after surgery. So one question that we get from some patients is, does the entire thyroid gland need to be removed? And where this question comes from is that in the past, many surgeons decided that maybe a surgery known as a subtotal thyroidectomy would be better for Graves' disease. The idea being that there is more inflammation of the thyroid gland. Maybe if we just cheat a little bit and we leave a little nubbin of thyroid right near where the nerve is and just not mess with that area, that we will decrease the rate of nerve injury. And also if we leave that little nubbin where the superior parathyroid may be close to, will also decrease our chances of injuring the parathyroid glands. And so for a long time, people thought that might be the right answer for Graves' disease. I think now, as our understanding has evolved, that's changed, and this study shows that very nicely. So this study looked at 200 patients where patients were randomly assigned to getting a subtotal or total thyroidectomy. And this figure kind of tells the story. What the two lines show is what happens to the amount of antibodies that cause Graves' disease over time after the surgery. The blue line is the patients who had total thyroidectomy. The pink line is patients who had subtotal. And you can see that after the operation, when you get several years out, the patients who had a subtotal operation had many persistent cases of still having the antibody around, where it was much lower when they had a total thyroidectomy. So it shows you that for controlling Graves' disease, total thyroidectomy is superior. And when they looked at the difference in surgical complications, the risk of low calcium, the risk of nerve injury, it was actually not different between the two groups for permanent complications. The patients who had a total thyroidectomy did have a slightly higher rate of temporary low calcium, but again, we can treat that with just calcium supplements after the surgery.
So sadly, we really don't have an ability to remove some magical percentage, like we remove 80% of the thyroid and then we cure the Graves, but also allow you to avoid being on thyroid hormone supplementation, like just the right amount of thyroid hormone that your body needs. We don't have the ability to do that, to leave just the right amount of thyroid tissue behind. If we do that, it only increases the risk that at some point down the future, the Graves will come back. You'll have to be treated for that again. And now if we're thinking about a reoperation, there's scar tissue in the neck. So we really don't want to do a second, thyroid operation.
That's right. Removing that little nubbin would probably be very hazardous.
So a plug to look at our website, which has a nice scar gallery with pictures like these to show you how the incision will heal after the surgery. So thank you for watching our video today. I just want to refer you to some resources that might be helpful. The top one here is our UCLA Endocrine Center website, which has some information specifically geared towards patients on a variety of endocrine conditions. The second one is from the American Thyroid Association, which has a nice section on Graves' disease, again, specifically for patients. And then the third one is the Graves' Disease Thyroid Foundation, which is specifically geared towards patients and can connect you with local resources and even other patients.
That's right. And if you'd like to come meet with us, speak to us, you can visit our website at the top here, which does have an appointment scheduling form. It also has the phone number to our clinic in case you'd like to make a phone call to schedule an appointment to see us as well. Thanks so much for watching today. I'm James Wu.
I'm Masha Livhits.
See you soon.